Hi guys.
Hi, Polly and Taylor here from Beaten Jeans.
Today we are interviewing Susie, who is a genetic counselor, and we have not done one of these interviews yet, so this will be very exciting. We have lots of questions for her.
We are very interested in learning more about genetic, and I have yet to meet with one.
Hi Susie, we see that you're on here. Just hit the accept button and then...
Hi! She is. Hi!
Hi there.
You look so professional, like you're in like a lab coat.
Thank you. No, it's just a blazer.
So where are you coming to us from today?
I am in Southern California. I'm a part of the Prevalent healthcare system, so I'm in our cancer center. I'm in one of the consult rooms.
Awesome.
Wow.
Very cool.
And how long have you been there?
It has been almost about 5.5 years now.
Awesome.
Wow.
Very cool.
Yeah.
Well, thank you so
Yeah.
much for sitting down and talking with us
very
today.
excited
Of
to learn more
course.
about what you do.
Yeah.
I'm happy to be here.
So why don't you tell us what is entailed in becoming a genetic counselor? What kind of degree is it that you have?
Yeah, so a genetic counseling degree is a master's degree after college, and it's a master's in genetic counseling. So it's its own programs. Since I found out about it maybe like 7 or 8 years ago, there have been so many more programs that have come up in the U.S., which is good because there's more opportunities for people to become genetic counselors. And so during that time, you learn about general genetics, you learn about different genetic diseases, and then you also learn, you go do different rotations in different specialties. And so a genetic counselor can work in general genetics, like an adult clinic, or pediatrics. I know prenatal is a big field as well. So a lot of people who have met with a genetic counselor have met with a genetic counselor through prenatal, during their pregnancy. Even just a lot of women who are over 35 will meet with a genetic counselor because it's considered high risk. And so that's enough to just see a genetic counselor. And then oncology, which is where I work, is another one of those big ones. So we see a lot of patients who either have a personal history or family history that's suggestive of a hereditary cancer syndrome, or people who already have mutations, so that we can follow up on appropriate recommendations for them, for their family members. And as I'm sure we'll talk about, those recommendations are always changing. So it's not so much a one-time thing, there's this mutation, that's it, because in 3 years, the recommendations might be different. And so it may be good for patients to keep up with their genetic counselors to learn, are there other cancers to be concerned about? Are there other things to be concerned about? Are we less concerned about these types of cancers now that we have more data? What are we doing to manage them? Do we have better ways to screen for those cancers? So all of that. And then, I mean, the field is just growing so much. People can work in industries and research in just about anywhere now.
Wow, I didn't realize it was so big and so
Yeah.
involved.
Yeah.
What brought you to become a genetic counselor? Are you affected by a genetic mutation in some way?
No, I actually was kind of at the end of my college career trying to figure out where I wanted to be. I was a psychology major and I was pre-med, and just neither of those paths seemed to really be what I wanted. I liked the combination, but I didn't really want to be a doctor. I didn't really want to be treating patients. And I didn't really want to be a therapist, but I did want to work with them. And so I actually just Googled, what can you do with a master's in psychology? And this came up, and I thought it was perfect because you do understand the science, the medical recommendations behind it. You work with doctors, you work in a hospital, but you're also working very directly with the patients. And your job is not to treat them. Your job is to help them understand what's going on and support them through that. So it's got a little bit of both of those things.
That is very satisfying.
Yeah.
Very helpful, I'm sure, to a lot of people. That's awesome.
Yes.
So Taylor and I have the CDH1 gene mutation, and we have never seen a genetic counselor before, and we've known we carry this mutation for going on 7 years.
Yeah.
So walk us through, like, had we gone through the proper channels and gone to see you, once we got our results back, and then we would reach out to you, tell us what that looks like if we were to sit down and meet with you.
Traditionally, somebody will come in either because they know there's a mutation in the family or because there's a new diagnosis of either breast cancer or gastric cancer at a young age that flagged them, and so they went to see a genetic counselor. And so let's say this is the first person in the family. Nobody else has had genetic testing before. What we do is we sit down with that person. We take a very detailed personal and family history, specifically with the focus of cancer, because that's what we're looking at. And we try to find out who else in the family has had cancer. Has anybody had cancer? No, nobody on dad's side had cancer. Okay, but he died at 35 and he had no siblings. Well, that's not really informative. And it's trying to also weed out a little bit of the specifics of the cancers, because sometimes people know grandma had cancer, but what kind of cancer was it? It was in the early 1900s. Maybe they didn't even know what it was. If somebody reports a family history of breast cancer, as you know, with this mutation, it's lobular breast cancer when we're concerned about. But how many people know whether it was lobular or not, right? And so trying to get an idea. And then
you're running into people who've been adopted too and may not even know their families.
Right. Right. And so after we take all that information, we sort of assess how concerned we are about there being a mutation. And we'll talk to patients about what mutations we might be concerned about. So if it's just a breast cancer history with no lobular breast cancer, you really talk more about like BRCA1 and 2 genes as the starter. But luckily now, panel testing is very common. So that means that you don't test for the 1 or 2 genes that you're concerned about. You test for a wide number of genes as long as the patient's comfortable, so that we're not missing something that in 3 years we find out, well, that was associated with breast cancer. So as long as the patient's okay with it, we talk about some of the limitations. We talk about some things like when you're doing genetic testing, especially if there's no history of cancer in you, there is a law called GINA that protects you so that you can't lose your health insurance and your employer can't use it against you. But there are other type of insurances that can ask. So if you don't have life insurance and you're 35 and you don't have cancer, you might have to think about getting life insurance or consider whether that was something you were thinking about before, because it's not that they have to decline you, but they could. And so sometimes you might want to get that in place before you do genetic testing. So we really try to make sure that patients are really aware of what the testing is and what the implications might be before they do that. If they decide to do the genetic testing, it's a blood draw or a saliva collection. Send that out to the lab. Usually within 3 weeks, we get the results back. And once we get the results, we'll let the patients know directly. So if we do find something, we'll have them come back for another appointment to really talk about, now that we found a mutation, what does this mean for you? What does this mean for your family members? And if things come back normal, we can talk on the phone, or they can come back for another appointment, because we still don't want to ignore the family history. And so we want to talk about, maybe somebody else in the family could still have a mutation, they should be tested. Maybe there is no mutation in the family, but there's still a lot of cancer, so we still want to be doing colonoscopies more often. So we take all of that information and do a full risk assessment for them. It's not just positive or negative, and that's simple.
Right. Wow.
Yeah.
So are you recommending somebody meeting with a genetic counselor before they even have the testing done?
If there's like a lot of cancer in the family?
Like if they're concerned about having a mutation, would you recommend people come see somebody like you first?
I would, because a genetic counselor is going to be the person who best understands their testing options, which testing is more appropriate for them. If they are anxious about getting too much information, maybe a panel that has more actionable genes, where we can be doing more screening. We have a plan after that would be better. Sometimes we'll have patients who come in with very limited testing, and we think, well, great, we know you don't have a BRCA1 and 2 mutation, but what about the other 15 genes that are associated with breast cancer now? So I think so. And also a lot of the questions can be answered. They'll understand which laboratory is going to work with your insurance better. What's your out-of-pocket going to be?
So, okay, so I'm not very versed on a lot of genetic mutations, but so we just tested for CDH1. So it's possible for someone to have a genetic mutation and then have multiples on top of that?
It's possible. It's not super common, but it definitely happens.
And then if we did have another genetic mutation on top of this, does that increase our risks?
I think it just depends what gene that mutation is in. So if if it's a gene that increases the risk for breast cancer, but you've had mastectomies, then you've kind of already reduced that risk. And if it increases the risk for breast cancer, but you're already doing extra screening every year, if you're not doing mastectomies, then you're already taking care of that risk as best you can anyway. But if it's a risk that has to do with colon cancer, then yeah, maybe colonoscopies would be indicated at a younger age or more frequently. And like I said, it's not very common for people to have more than one mutation, but it is possible.
Right. And so are they adding, or are they discovering more genes to add to the panel like every year?
Totally.
How many do they screen for?
It really, really depends. The panels really matter. And so that would be another tip. If you have genetic testing, or if your family member had genetic testing, give that to your genetic counselor so they can look at what they were tested for, right? Because if somebody came in and said, people will say grandma's breast cancer wasn't her genetic. How do you know that? They tested for BRCA1 and 2 15 years ago. 15 years ago, the testing for BRCA1 and 2 even wasn't complete. We weren't looking at all of the mutations. So there are some mutations that we're looking at. I would say anywhere between maybe 80 is what a lot of these laboratories are testing for kind of in their standard large panels. But there are some tests that are 150 genes. There are some tests that are 30 to 40 genes. So it does vary a lot.
Okay.
Are you well versed in all the genes? Do you have to be like up and on top of all of that to be in your profession?
There are some that are more common than others. So I'm going to be a lot more up to date on cancer genes than on some pediatric genes, because it's just not what I do every day. I'm going to be much more up to date on the recommendations for those genes. But some of the genes having a mutation is so rare that you also have to be very well versed at where to find that information. Because if I haven't seen a patient with that mutation in 4 years, I basically have to start over just to see what have we learned since then. What are the recommendations now?
Right. Yeah, exactly.
Have you heard of a lot of people with the CDH1?
It's not a very common mutation. It's definitely one of the more rare syndromes, which makes sense. Typically, the more the higher the risks, the lower the prevalence is just sort of a rule that we have. But because we are doing panel testing now, and so we'll have people who come in who think, there was some breast cancer in the family and maybe somebody had died of like colon cancer, and then it's CDH1, right? They're all lobular cancers and that person had gastric cancer. And so with these panels, we are learning that there are a lot more people who have CDH1 mutations, and we're also learning that the risks we thought were associated with CDH1 mutations are maybe not as high as we originally thought.
Right.
And so we're getting more and more data.
We're hearing that too.
Probably as more people are getting tested and less people are developing cancer, it just sort of, the statistics of it work.
Because don't you have to have a specific criteria in order to be tested for certain things?
In general, yes. It's another thing that has changed a lot in the last few years is that the cost has gone down significantly. So I don't know, 5, 6, 7, 10 years ago, getting tested for 2 genes was $3,000. Now you can get tested for 85 genes for $250. Mm-hmm. So even if you don't technically meet that criteria, you might think, I want to do this testing anyway. I want this information. And it's just a lot more accessible. Laboratories have a lot more financial assistance programs for people who want to do it, and cost is a barrier. And so it's definitely become a lot more common. And we're testing for a lot of other things too. And you can see that even in the guidelines for who should test for CDH1 mutation that used to be very strict. And every time it's updated, it's a little bit less strict. There's a little bit more leeway. There's a little bit more like, well, maybe if there's this many cancers, or maybe at this stage, or maybe this age doesn't matter quite as much. And so it's definitely becoming more open for the testing criteria as well.
Right. And since you have a psychology degree, are you also acting as a counselor? Because like for us, when we first got diagnosed, we were a mess and we didn't feel like we had anybody to go to talk us off the ledge. Are you are you involved in that?
A little bit. We do get some training also in school. I will say my psychology background as an undergraduate psychology degree is very helpful, but I am by no means a psychologist. I think it's fascinating, but I am not a clinical psychologist in any way. But We do get some training mostly on trying to have people be comfortable when talking to us, because even just talking about family history of cancer can be difficult, recounting family members, loved ones who have died of cancer or who went through a difficult cancer treatment process or anything like that, or just because families are complicated. And just talking about family sometimes can be really hard for people, and just trying to figure out or realize that they have no idea about mom's side of the family or dad's side of the family. But also when giving news like this, or somebody who's just diagnosed with cancer and talking about their cancers, and it's a lot to deal with in a very short amount of time. So we do try to be empathetic, to help the patients through that. It's not a long-term therapy. We have wonderful social workers here. We have wonderful other resources. We have nurse navigators who are following through the process more closely, so that every step of the way they have somebody who they can rely on. So it's not that we're providing therapy, but we do provide support where we can.
And you can always just refer them. Like, I'm noticing you're needing a little bit more help, and I'm going to put you in touch with somebody else. Like that.
Yeah, and you'd be surprised how open people are to that. I think as a young genetic counselor, you think people are going to not react well to that, but people are usually very grateful that you've noticed that and that you want to help.
Oh, that's awesome.
Good.
Yeah.
So family tree plays a very important part in that. And do you think that it always does? Do you mostly look at that as far as risk? Is that how you come up with the risk associated with the mutation?
Not with the mutation specifically. So when we're trying to assess how much we think a person should have genetic testing, like, am I going to offer this to you, or am I going to strongly recommend this to you? The family tree plays a big role. But if somebody is 30 with lobular breast cancer, I'm going to recommend it even if nobody else in the family has breast cancer or any other type of cancer. So the personal history also depends, and really plays a role there too. For the managing the risks, CDH1 is different in that the family history also does play a role. So having a CDH1 mutation and having a certain family history could potentially guide where your treatment goes, but we're really at the infancy of that, and we're still learning so much, because I'm sure you've heard of the people who have their stomachs removed. The overwhelming majority, if they're combed through appropriately, they will find some signs of cancer, some of those signet ring cells. But we don't know, we don't understand them. They're clearly there in most people, but we don't necessarily know how quickly that goes from being a small focus to being a cancer that's an actual problem. Right. And so we are just trying to learn so much.
Right. Mm-hmm. That was something that we wanted to talk to the doctors about, is adding like some kind of diary that, like, I don't know, we're just wondering if like lifestyle plays any role in turning the CDH1 gene on,
or any other mutation.
It. Yeah,
like, I mean, diet and lifestyle.
Right. Is that something that you talk to your patients about, their lifestyle choices?
I don't specifically. I would say in general, there are very kind of basic general nutrition tips, like not smoking, trying to limit alcohol, to not doing it in excess, eating fruits and veggies, working out just to be active. But we have a great dietitian, so if they have questions, it's the dietitian who I'm going to send them to, because I would not know what to say. I don't know that there's a lot of data on that, not something I've specifically looked into, but I think it's a great question, because it's right there in the GI tract, and maybe there is something that we can do.
Yeah, someone who's eating donuts and drinking a 6-pack of beer every night might trigger their gene more so than someone who's working out and drinking water and protein shakes all day. I don't know. We don't know though. Yeah, who knows?
Right.
So do you work nationally? Like, if someone lives in New York and they want to speak with you, do you do Zoom calls like this, or? The
tricky thing is that for genetic counselors have to be certified, and that's a national thing, but each state may or may not have licensure. So in California, we do have licensure. So a genetic counselor who's practicing in California or working with a patient in California has to be licensed in the state of California. But in Texas, they don't. So I've gone home to Texas and been able to see my patients in California because there's not that issue, but some other states do have that. But we have the National Society of Genetic Counselors has a great resource of genetic counselors. It's just called Find a Genetic Counselor. So you put in your area and the expertise you're looking for. And now, especially with the pandemic, you can put in, are you open to seeing somebody through telehealth, or do you want to go in person? And you can find a list of genetic counselors who would be available in that area. I'm happy to talk to people kind of unofficially, but I can't do a genetic counseling appointment with them.
Right.
Okay.
Mm-hmm.
Well, that's helpful.
Yeah. So can you just tell someone who's watching this who might have a fear of having a genetic mutation or something like that, what their steps are to, like, how do they begin? Where do they go to get their blood drawn, or how do they get how do they get signed up with a genetic counselor? They would do that first, right? So what was that website that you said?
So you can just Google Find a Genetic Counselor.
Okay.
And the top one should be NSGC, that's National Society of Genetic Counselor.org. And that's the official one.
Oh, okay.
I would recommend going through a genetic counselor, like I said, because they'll give you more information. Even if you're just an anxious person and grandpa had prostate cancer in his 80s and it wasn't aggressive, but now you're nervous because there's cancer in the family and you just want to get tested, I still recommend doing that through a genetic counselor, because they'll be able to then interpret that test for you as well, rather than just tell you positive, negative, and you're on your way.
Okay. Cool.
I wanted to ask you about the de novo, the people who have the mutation, the first in the family, where there's never been a mutation before, and they're the first. Is that something that you're seeing more of recently, or has that always been present? Can you talk about that?
Yeah, it's always been present. There are some genes where we know de novo mutations are more common, and there are some genes where they're not as common, but that's why the family history plays a role, but it's not everything. And that's why a person coming in who is maybe in their 40s or 30s with a cancer, there's always a possibility that they're adopted, that their parents use a sperm donor, that dad is not dad, so that is something we have to keep in mind. But there is also always the possibility that it could be a de novo mutation. And so you never want to ignore a red flag, even if everything else looks clear, because we never know. We just don't, maybe somebody says there was no cancer in the family, but they never went to doctors. So they died of a car accident, but they had cancer. You just don't know. And so if there is something that makes you concerned, you want to make sure to kind of focus on that and recommending the genetic testing. Maybe your risk is going to be a little lower if nobody else has had cancer in the family, but there's still enough of a concern that you want to do the genetic testing just to get that information and to rule that out. If there is no mutation, great. Then now we know, now your family knows. But if there is a mutation, then for some reason it may have just presented in that person first. We don't know why. Maybe lifestyle, maybe stress, maybe just by chance, and that could happen.
Right.
Wow.
Okay.
Good.
So in your opinion, do you think that preventative surgeries are a good way to go, or do you think surveillance is just as good?
I think that's a very difficult question.
I know, it's really broad.
Especially in CDH1, because some other, even like in BRCA, we recommend having the ovaries removed by a certain age in women who carry a BRCA mutation, because that risk of ovarian cancer is higher. We don't have very good screening. And that's pretty life-changing. That can put somebody straight into menopause, and it can be a whole challenge on its own. But there are some things that they can work with. There is hormone replacement therapy, maybe. There are some it's just not quite as life-altering as having your entire stomach removed. And so I really feel for people who have a CDH1 mutation, because that is such a huge decision that has to be made. And doing it or delaying it is such an important decision at that time, because you don't, right, like you definitely don't want to develop that cancer, but you don't want to not have a stomach either. And I will say that watching your talks and watching other people who have gone through this, I've been so amazed at how people have bounced back. And not to say that I'm not sure it has not been an intense journey with a lot of relearning how to live and do basic things, because I'm sure it's life altering, but it's been heartwarming to see how people bounce back and how people rebuild and how people,
it is.
yeah.
They're all
they're
so
not,
strong.
they're,
I'm just
yeah,
really impressed. They make it seem like it's no big
exactly.
deal.
And I love what
Right.
Dad said. He said that the having your stomach out is hard, but his diagnosis with cancer made everything so much harder, his life harder. And that's something that we need to think about. Like, do we want to take that risk and have to deal with having your stomach out
Chemo.
and doing the chemo and dealing with the potential of it growing back? So I think,
Yeah.
yeah.
I think my recommendation would be talk to your surgeons, talk to your oncologist,
Right.
follow current guidelines. Unfortunately, it is the best we have, and it is somewhat limited on data. It is the best we have. But the good news is there's a lot of interest, there's a lot of research, and hopefully we'll be learning more and more. So if you're concerned about your children, first of all, we typically don't test children until they're a little bit older unless there's certain situations. But keep in mind that those children, by the time they're old enough to be considering this, maybe we will have more information.
Right.
So
Exactly. Yeah.
maybe we will have better tools. Maybe we'll, find some sort of diagnostic test that is excellent at detecting diffuse gastric cancer.
Right.
So there's hope for the future.
Perry.
I know.
Yeah. Perry Guilford has some stuff in the works we're very hopeful for the next generation.
Yeah,
Yeah.
exactly.
But yeah, we need,
Yeah. And is it true that I don't know if it's the BRCA1 or BRCA2 also has a risk for stomach cancer?
In BRCA1 and 2 genes, even though they're pretty well established, we're still learning more about them. So it's not one of the central cancers that we typically talk about. There is some idea that there could be like a uterine cancer with one of them, maybe, and things like that. I wouldn't say that gastric cancer is currently one that I would talk to my BRCA patients about having their stomachs removed, especially if there's no family history. There are other syndromes, like there's a syndrome called Lynch syndrome, and there's some gastric cancer associated with that. But yeah, even some things like BRCA1 and BRCA2 that we've known for a lot longer, and we know a lot more patients who have had them, and there's more research. We're still learning more and more because we're still testing people who we thought maybe they had colon cancer, and all of a sudden there's a BRCA mutation, and that happens. And it's a challenge to try to understand with the patient why this came up when it wasn't at all what we were talking about, but it's also giving more data for us to understand maybe there is a little bit of an increased risk of certain cancers with certain things, but maybe it's not that high. Maybe we don't have to have our colons removed. Maybe we just need to do colonoscopies. And so it's an ongoing process for sure.
Is there a national data bank where you are inputting these individual families' risks so that you can go and then the numbers are calculated that way, or is it just specific to your hospital?
Yeah, no, that would be great. Unfortunately, no. Hospitals will do their own research. Laboratories will do their own research. So laboratories are huge databases, especially specifically genetic laboratories who focus on cancer or whatever it is, because they end up getting all of this data and all these patients. And so it's really important when we're filling out the family history to give that to them as well, even though they don't trace it back to your family, but they trace it back to family, whatever that has been de-identified. But then if they're able to track what side of the family it's coming from, things like that, they can start to look and maybe be like, well, we didn't think there was colon cancer with this, but is there? Or we thought there was colon cancer, but we have had 100 people test this year, and none of them had colon cancer, and none of them reported colon cancer in their families. So do we need to look at this again? Maybe. The way we find mutations to begin with, especially like in cancer syndromes, is we find a family that's very striking. There are so many stomach cancers. Why? They're so young. Why? And then we find it. And it's kind of like an overrepresentation of the risk, and because that's how you narrow it down to actually identify that. And then as the time goes on and you start finding it in other people, you start learning a lot more. And it's not just this one family that was striking enough for us to find it, but there's a lot more variability.
Interesting. And so are you seeing that through publications, like people might publish their findings and then you're seeing that and then you find their publications, but you aren't all necessarily communicating with each other?
Right, but then there are foundations that are set up that are looking at those and trying to do research specifically for that type of cancer, that gene mutation. Or there's the NCCN, which is the National Comprehensive Cancer Network, and so they put up guidelines a couple times a year for different cancer sites, and they also update that, and that's a group of surgeons, doctors, radiologists, oncologists, genetic counselors, a whole group of people who come up with these recommendations, and they are also constantly being updated. And those are some of the resources that we use, because one paper can be really interesting, but if it's not reproduced, if we can't get data again that shows that that's true, then maybe that was a one-off. Maybe that's really interesting, but that was a very specific case. And so you really have to take all of that data together to make a decision for a group, rather than just one paper that showed something.
Right. Wow.
Interesting.
You have to be working and studying a lot. You have a lot of continuing education that probably happens every day.
We do. That is some of the best part of our jobs, because we're always learning and we're always,
It's so cool. And you get to see all the advancements happening too. That's awesome.
Yeah, it'd be rewarding, I think.
Yeah, I think so too.
So do you have any bits of advice or wisdom you want to share with us before do you have any more questions?
I don't think so. I'm looking at our questions over here.
Yeah.
I think we went through them all.
So I have one. I don't know if you guys know what the CDH1 gene does.
Oh,
well, yeah,
I think
talk
this
to us
is
about
so
CDH1 gene.
interesting.
Yeah, please.
So one of the things that CDH1 does is it produces a protein that functions, amongst other things, to make sure that cells are adhering to each other. So it's kind of like making sure that cells can attach. And that's normal cells do that all the time. If CDH1's not working, then that attachment doesn't work as well as it usually does, which is why instead of having a stomach cancer that's a tumor, or breast cancer that's ductal, that's usually a tumor that's easily seen, we see the diffuse gastric cancer with CDH1, and we see the lobular breast cancer that's more like a line, like a dotted line on imaging, because the cells aren't attaching to each other. So even though the cancer is there, instead of becoming a tumor, a mass, they just sort of are around, and they're just sort of more individual cells near each other, because part of their problem is that they are not joining to each other like a tumor.
Wow.
That's that E-cadherin, right?
Yeah,
That's
exactly.
in our breast as well.
Mm-hmm. Yeah, and so one of the tests to see if a cancer is lobular specifically is to see is the E-cadherin there or not. And if it's negative, then that tells the pathologist that that's a lobular breast cancer.
Right.
Oh, interesting, because we've had a couple people, probably 3, they actually felt a lump with their lobular.
Yeah.
So it's probably just not this blanketed, it's always this way,
Yeah, and it's still cancer, and it's still cells that are growing and dividing more than they should, so there can still be a mass. But when you look at lobular breast cancer, typically in imaging, the reason that it's hard to find in like a mammogram is because that doesn't come up so well. So like an ultrasound or an MRI, I believe, are better at finding lobular breast cancer because they're better at identifying that type of change rather than like the little bit mass that might be like a ductal breast cancer.
And they even describe it as like a shadow on the image, not like a dark mass.
Right.
Wow, that's so interesting. Thank you for.
So would you recommend not even going through with having mammograms if you have CDH1, just doing MRIs?
I don't think that that's true. I think most cancers are sporadic, and so most cancers are just going to happen on their own, even if you don't have a mutation. And so that's where it's tricky. Anybody who has a mutation in a gene that increases the risk of certain cancers still has a risk for other cancers, not as high as the ones but they still have a risk for everybody else. So even if your syndrome doesn't increase the risk for colon cancer, your colon cancer screening should still be like everybody else's.
Right.
And so there's all.
Because I always wondered why they had us do a mammogram.
Right.
Yeah. What do you think about thermography for breast screening?
Ooh, I don't know. That's a great question for a radiologist, or rad tech, but I definitely don't have enough knowledge in that to be able to comment.
Right. That's okay.
Well, that's very interesting. I'm glad that you explained the CDH1.
I think sometimes we understand the genes a little bit, but I think with this one, it's kind of a satisfying explanation, at least, of why it's those specific types of cancers. Right. So at least we have that little amount of information to go on.
So what is it with the BRCA then? What makes them so prone to cancer?
With those, it's some more of the how DNA is repaired when it's damaged. And so if DNA is damaged and it can't repair itself, then that cell now has a mutation in it. And then if you keep losing the way that certain cells are working, that cell's going to keep growing and dividing. And so that's going to eventually become cancer.
I thought our DNA was damaged too. That's how Dr. Guilford could see it.
Yeah, no, it is similar, but we still don't necessarily understand. I mean, we do understand it, but it's a little bit more broad, I would say, with BRCA1 and 2, whereas CDH1, that specific type of not joined cancer is due to that loss of function.
Gotcha. Okay. What's the most prevalent type of mutation that you see typically?
BRCA1 and 2 are somewhat common. There's some what are called moderate risk genes, like CHEK2, ATM. They just tend to be a little bit lower, but we tend to see those a little bit more as well. Just they're more common. And then there's some mutations that are more common in certain populations. And so if you're working with a certain population, you may find that you're working with certain mutations more than others.
Right.
I have another question, because our cousin has the ATM and CDH1. Do you ever see mutations communicating with each other, or are they working independently to do things?
It is so hard to tell sometimes, and it's something that has to be studied. And so for some cases like that, there may be a paper out there that looks at it, or a paper that looks at a couple of families who have something like that and whether their risks are higher or lower. But it's really difficult to predict just kind of theoretically.
Right. Yeah. Okay.
Yeah.
There's a lot of unknowns.
Yeah, there is. Ever-changing science, right?
Yes. Absolutely.
Well, this has been so helpful.
I know.
I think it would have been really nice and helpful to have met with somebody like yourself.
I think so too.
It would have probably been a lot easier emotionally
Mentally,
and psychologically
to accept it, right? Yeah.
to have somebody just to kind of explain it as well as you have just done for us. And so we appreciate that.
Yeah.
Well, thank you. And I recommend that anybody who's curious, you can always have a genetic counseling appointment and not do testing, or go in and do a genetic counseling appointment to make sure your genetic testing is up to date, or to make sure that the guidelines you're following are up to date. It doesn't mean you have to do a test if you go see a genetic counselor. It's a lot of the education and the support behind it as well that we focus on too. So if you're curious, if you're interested, if you have questions, definitely make an appointment with a genetic counselor. Have them answer your questions to your case specifically with your family history, with your personal history, and make those recommendations individually to you. And I want to thank the two of you also for doing this, because I think for us, like I said, it's been really inspiring to see the journey and to see, and we're not seeing somebody who has their stomach removed 10 hours later. We're seeing somebody a little bit further out, but it's so nice to see that the strength that people have had after going through something like that, the way that they've been able to go back to having a functional life, and then even for some people, created stuff out of this experience, the way that you're supporting everyone. And I think we just talked a lot about papers and science and recommendations and data. And that is a lot of times where we're coming from, because that is what we have available to us, and that's what we are presenting to our patients. But it's such a good reminder to clinicians. And I recommended this page and these lives to my colleagues, and I try to jump in whenever I can, because it's such a good reminder that this is such a personal experience for somebody, and these are people that we're dealing with, and their experiences are going to be different, and there's going to be things that we never thought about talking about. And listening to you and the people you've interviewed have opened my eyes to some of the issues that are not, just like digestion issues, but other things that we don't consider. So thank you for doing this for your community, and also for us as well.
That feels that feels so good to hear that, because it feels good to know that we're doing good for other people. So thank you for saying that. Yeah. Good. Oh, well, thank you so much, Susy, for taking time out of your busy day to talk to
Thank
us.
you for all the work you're doing for
Thank you.
and for caring so much.
Thank you.
You don't always find that in healthcare workers, so we appreciate you.
Yeah.
You're so much. You have so much
joy.
I don't know. You're passionate.
Yeah, passionate.
Yeah. Yes, definitely.
Oh,
Well, hopefully we'll be in touch and let me know if
definitely.
there's other questions.
Awesome.
Great.
Thank you
We
so much,
appreciate you, Susie. It
Susie.
was so nice meeting you.
Nice to meet you
Bye.
too. Bye.
Bye.